Good afternoon and welcome to the afternoon breakout session entitled Transitions of Care and the Role of the Acute Care Bedside Nurse. I'm Karen Harris and I'm the Division Director of Clinical Quality for the HCAHPS Division. I've had the pleasure of serving as a member of the Planning Committee for this year's Safety Summit. I hope you've enjoyed the session so far today, and you'll certainly be glad that you chose this session for your afternoon breakout. It's now my pleasure to introduce our speaker for this session. Sarita Rhodes-Vivour is currently the Associate Vice President of Acute Care Services at Virginia Hospital Center. She's a visionary leader with 15 years of clinical and leadership experience in various disciplines, including critical care, cardiovascular neuroscience, orthopedic surgery, oncology, medical, surgical, and rehab nursing. She has a Master of Science in Nursing Leadership and Management from George Washington University in Washington, D.C., and a Bachelor of Science in Nursing from Tuskegee University in Tuskegee, Alabama. We may have time for one or two questions at the end of the presentation, so feel free to put your questions in the Q&A box. Join me now in welcoming Sarita.
Hi, everyone. Thank you for having me today. I'm going to go ahead and share my screen. All right, quick check there. Karen, can you see my screen okay?
Yes, ma'am.
All right. Well, thank you guys for having me today. I'm Sarita Rhodes-Vivour. Thank you for the introduction. I would like to thank the VHA and the Virginia Association for Healthcare Quality for allowing me to do this breakout session for the Safety Summit today. And thank you guys all for joining. Today, I'll be giving some information on why transitions in care are so important and how the frontline nurse and other key members of the care team can help make this a smooth process. I'll give an opportunity to ask questions at the end of my presentation, and I ask that you put your questions in the chat box, and Karen will read them out for me. So now more than ever, we're under enormous pressure and face many new obstacles when it comes to transitioning patients out of the hospital and keeping them from returning. Transitioning care across settings are vulnerable exchange points for patients and caregivers that could contribute to higher risks of poor health outcomes. The Institute of Medicine and National Quality Forum identified improving transitions across the continuum from acute care to home as a national priority. Nurses really have an integral role in care coordination activities and can help to transform healthcare delivery for patients in the acute care setting. As I go through this presentation, keep in mind, my background is not case management. Like Karen said, my background is more of overseeing the inpatient nursing units. And in my current role, I oversee all of the med-surg units here and the ICU at Virginia Hospital Center. So my background is definitely not case management, but the case managers focus more on coordinating and planning of resources, while the nursing staff are more focused on preparation and setting the patients up for success for the most optimal situation post-discharge. But before I get started, I'd like to thank you all for your service, all of the healthcare workers out there, for your unwavering commitment and sacrifice during this pandemic. We're definitely not living in normal times, and we as healthcare workers have had to adjust to our new normal with COVID. It's been tough, and as healthcare leaders, we've had to manage staffing shortages while still trying to successfully achieve our organization's goals and continue to run the hospital operations effectively. So I hope this talk today will give you a few strategies that you can use at your organization. And for those who are not in the acute care setting, I hope that you may also find some key takeaways and also find some ways to apply them to your areas of expertise. All right, so my agenda today will focus on how we measure success of care transitions, discharge preparedness, and strategies to improve transitions of care. So first, let's talk about how we measure successful transitions of care. When a patient leaves our hospital, how do we know if we did a good job transitioning them and preparing them for the next step in their journey so they don't return back to the hospital? So the main two indicators that we look at in the hospital to measure this are 30-day readmission rates and HCAHPS. Readmission rates. So let's start by talking about the national problem we're facing with readmissions. This slide gives us some national data on readmissions from AHRQ. And as you all may know, hospitals can be penalized by Medicare for a high readmission rate within 30 days of discharge. So it's estimated that roughly 2 million patients are readmitted each year, costing Medicare $26 billion. And many of this is from those avoidable readmissions. Discharging from a hospital, it's a critical transition point in a patient's care, and incomplete handoffs at discharge can lead to adverse events for patients and avoidable readmissions. Hospital readmissions may indicate poor care, missed opportunities to better coordinate care, and result in unnecessary costs. This diagram really gives us an idea of how impactful readmissions are to the healthcare system. And although this research by the Healthcare Cost and Utilization Project initiative was done in 2010, this diagram here still really gives a good depiction of that revolving door effect and who is most commonly being readmitted within 30 days. The middle section of this picture shows the patients who were readmitted based on common procedures and diagnoses. And at the bottom, it shows the readmissions by payer, with Medicare and Medicaid being the highest. So as you all know, with COVID, we've experienced a whole new set of challenges related to readmissions. Good thing is, our hospitalization trends in Virginia are going down, as you can see from, I pulled this data last week, but we saw some of our highest volumes with Omicron, as you can see the spike in January in Virginia and nationally. And as I mentioned, COVID brings in a new set of challenges. And this study by the CDC shows that 1 in 11 patients hospitalized for COVID were readmitted to the same hospital within 2 months. Risk factors included being greater than 65 years of age, presence of certain chronic conditions, hospitalization within 3 months preceding the COVID-19 hospitalization, and discharge to a skilled nursing facility or home with home health care. The diseases of the respiratory or digestive systems or circulatory systems were readmitted patients' most common discharge diagnosis. And understanding the frequency of and potential reasons for readmission after COVID-19 hospitalization can help inform clinical practice and discharge disposition decisions. So now we'll move on to the next indicator of successful transitions, which is the data we get from our patient experience survey. So this helps us to understand the patient's perception of their discharge process. As many of you know, in most hospital settings, we use HCAHPS to measure the patient's perceptions of care. And this survey is the first national standardized publicly reported survey of patients' perceptions of hospital care, and was developed by CMS and AHRQ. And it's also part of a broader value-based purchasing initiative that ties reimbursement to quality outcomes. So HCAHPS has 6 composites. The HCAHPS questions are answered on a Likert scale to report the degree of agreement with a statement using strongly agree, disagree, and strongly disagree, or I don't know, or I can't remember. Today, I'm just going to focus on the domain number 6 on this list, which is the discharge information. As I mentioned, there are several domains in this survey to indicate the patient's perception of care, focusing on the discharge and care transitions domains today. But these questions are not answered on the Likert scale, but they're more on a yes/no scale. And as nurses, we often focus on the immediate needs while the patient's in the hospital, what's right in front of us at the moment. And we don't often spend as much time planning for the future. We should focus the process of discharge on the patient and not what's easiest for the clinician. And we need to start talking about discharge plans on admission and not at the end of the stay. I'm sure you have heard this before. We've heard it all the time that discharge starts at admission. But what does that look like? And how can we make this happen consistently? The discharge plan of care should be reinforced daily. And the plan should always, the patient should always be thinking about what steps need to be taken next to get home. So the questions here are, after you left the hospital, did you go directly to your home, to someone else's home, or to another healthcare facility? That's the screening question. And then the sub questions are, during this hospital stay, did doctors, nurses, or other hospital staff talk with you about whether you would have the help you needed when you left the hospital? And then the next question is, during this hospital stay, did you get information in writing about what symptoms or health problems to look for after you left the hospital? The next section related to discharge information asks questions about care transitions. The care transition composite measures the aspect of care that goes home with the patient, along with their meds, their discharge folder, and care instructions. And this aspect of the HCAHPS survey asks questions regarding how the hospital staff help the patient prepare to leave the hospital, and are answered on a yes/no scale as well, not the liker. So these questions came about as the evidence showed that many patients left the hospital not knowing how to approach the next steps in their care. And these questions are intended to focus care providers' attention on improving performance on issues that make positive responses to this aspect of care continuum more likely. So the questions are, the hospital took my preferences and those of my family or caregiver into account in deciding what my healthcare needs would be when I left the hospital. When I left the hospital, I had a good understanding of the things I was responsible for in managing my health. And when I left the hospital, I clearly understood the purpose for taking each of my medications. So now that I've talked about how we measure success, let's talk about how we get the patients and families prepared for discharge. The nurse's key responsibility is to partner with case management and other members of the care team to make sure the patient is ready for the next step. We can't keep the patient in the hospital forever, and we need to make sure we have done all we can to get them ready to go home or to their next phase of recovery. And in healthcare, we generally consider discharge to encompass the 72 hours immediately following the moment the patient leaves the hospital. A safe and successful discharge is almost always the end goal of a hospital stay. So this was something that really stuck with me during my research on this topic, and it further justifies the need for better discharge planning. A recent study was done by the Always Culture Company out of Texas, which I love that name, but it shows that the patients surveyed at discharge, out of the patients surveyed at discharge, 41% could not state their diagnoses, 37% couldn't state their purpose of their meds, and 86% of them could not identify the side effects of their meds. And this is a problem, and it's an indicator that the patients did not have a very good discharge education or planning. And another study that I researched was that patients who understood their post-discharge plan had lower rates of subsequent hospitalization or ED visits than those who did not. We also have some real barriers, when it comes to doing proper discharge teaching and preparedness. The barriers and risk factors listed are some of the most common and what we are also seeing at my facility as well. So many hospitals are dealing with capacity challenges. There's no beds or no staffed beds. This was a challenge before COVID, but even more so now. And this puts pressures on facilities to rush the discharge process, which could result in the care team not being as thorough with the discharge planning. Nursing staffing shortages present the challenge of the nurse having time to actually do good discharge teaching and preparation. The nurse may feel overloaded or even rushed. Outside facilities such as skilled nursing facilities are filling up, especially now with COVID. And early in the pandemic, they had very strict rules, which made it difficult to discharge a patient. So many also didn't have the proper PPE. Many of those facilities didn't have PPE or even the knowledge on how to care for those COVID patients. And now they're also facing staffing shortages like everyone else in the country. Case managers and members of the interdisciplinary team's involvement is also key. For example, if the case manager is not on the unit visiting the patient and communicating with the nurse, the planning process kind of falls apart. So during COVID, this was especially difficult because many of the case managers are working remotely. And this puts a lot of the burden on the nurse to fill in the blanks where needed. So I'm not sure if you experienced that at your facility, but this was the case at many. The next is interdisciplinary communication, which is very important. At my hospital, we have what we call care coordination rounds, which is a meeting of providers, nurses, case managers, and oftentimes pharmacy and physical and occupational therapy are present. And This interdisciplinary team is critical in planning the next steps in the patient's care. I'll talk more about this later in my presentation. And then weekend challenges. We all experience this where there are issues on the weekend. So there was an article by the Society of Hospital Medicine that showed that inpatients admitted during the weekend may have a higher mortality rate compared with patients admitted during the weekdays. And this is due to the lack of resources in many hospitals during the weekends. This is something that we really have to address in our hospital settings. And then lastly, challenges to understanding the discharge instructions include patients' lack of physical or emotional readiness to learn, and the fact that patients, that the family members or the patient caregivers may not be consistently involved with the educational and discharge planning efforts. Discharge instructions may be unclear and may not be tailored to the patient's individual learning style or their social determinants or their health literacy needs. Also, education provided from different healthcare providers may include conflicting or confusing information, which we see, and discharge information should be written clearly and in a patient-friendly terminology and should be tailored to that patient's learning style. And I'll talk a little about this later on in my presentation as well. So, what are some of these tactical things that we can do to tackle these challenges and really to impact our measures of success that we discussed and our discharge preparedness? So strategy number one is communication. The communication board is something that you'll often see in a patient room. It's also known as the whiteboard. I like to call it the communication board because it really is a communication tool between the hospital staff and the patients, and it's a way to engage patients in their care. But it really all boils down to communication. The more information the patients and their loved ones have, the better we can plan. Communication errors cause 65% of sentinel events in most hospitals, according to recent studies. And some common elements that you'll see on a whiteboard really includes the patient's plan of care, like what their plan is for the day, what's their expected discharge date, and throughout the patient's stay, we need to take the steps to make sure the patient not only knows the anticipated discharge date, but that they also have the help they need when they get home. Remember, that was one of those questions from the HCAHPS survey, but it needs to be written down and discussed again and again and again. It's important that the nursing staff keep the board up to date and relevant to that shift's care goals. The patients really rely on this tool. They're looking at this board all day long, and they really rely on this tool to help them know the next step in their care. Some of the best performing hospitals use a phrase, plan for the day, plan for the stay, as an easy way to engage patients around the plan. And they write these phrases on the board to cue the patients and loved ones to discuss those long and short-term goals. Strategy number two is my favorite, bedside shift report or bedside handoff. Bedside handoff, it really allows the patient and the families the ability to contribute to their plan of care. And this is a time when, the two nurses assess the patient together. It provides them that opportunity to do this interaction with the patient together. And it reduces, patient safety errors by doing this. Research recently published in the Journal of Nursing Quality, Care Quality found that bedside handoff relieved anxiety and improved patient satisfaction. And this is an activity really that nurses do every day. As leaders, we audit this. That happens all the time. But it's critical that we optimize this opportunity, and we should really use the communication board at this time to indicate things like the expected discharge date. So they'll always have this date in mind. The patients always are thinking of this date, and they'll work towards reaching their goal for discharge. This is also a time when nurses can assess the patient and caregiver concerns and any risk factors associated with non-adherence, which we do find that in the hospital setting as well. And these concerns should also be addressed throughout the hospitalization. Strategy three is care coordination that I mentioned earlier. So this may look different at different organizations, but this is a time when the interdisciplinary care team touches base around the discharge plan. In my opinion, this is where all the magic happens and where we can make the biggest impact when it comes to discharge planning. We have what we call at VHC walking and talking points at my hospital. And this gives the guidance on what to discuss during this care coordination meeting, and what to take back to the patients. The meeting is typically led by the nurse leader or the charge nurse, and it includes at minimum the physician, the nurse, and the case managers. Pharmacy and PT and OT are often present, especially on the surgical units. So I have here on the screen kind of what each person that's involved with and what they're responsible for. So what does this look like at your organization? Is it consistent? Are your expectations clear of what should come out of this meeting? Is it at a standardized time? Ours is at a standardized time for every department. Does it include frontline staff? It's very important that the frontline staff are able to join this discussion. For us, if a team member can't come, because that's often a barrier, somebody can't make it, they'll communicate any updates through the Epic Secure Chat system to the charge nurse or nursing director. So we like to use our Epic Secure Chat at BHC. And I like having the pharmacists there because they really play a crucial role in the medication safety during transition of care through the MedRec and discharge education process. And they also help to make sure the patients understand their meds and can help us obtain them after leaving the hospital. Strategy number 4 is discharge education, which is clear discharge teaching, basically. So discharge education should be provided throughout the hospitalization and then confirmed on the day of discharge. There's a lot of tools available to help facilitate discharge education, such as TeachBack, which addresses the patient's understanding of the discharge instructions. And another strategy is to incorporate a discharge checklist. I'm a fan of checklists, but this really does help keep all of our ducks in a row, keeps us consistent. Nurses should take their time when giving discharge instructions. And one study found that 1 in 10 discharges included errors in discharge instructions, incorrect discharge medications, or a good catch. And I'm sure you guys have experienced where somebody will go home with a completely different patient's discharge instructions. So this is really a critical part of the discharge process, and it should be thorough and uninterrupted. One of my highest performing units at BHC in this domain in particularly actually hands off their phone during discharge teaching, and they put a do not disturb sign on the patient's door. So we know this is uninterrupted time and they're doing discharge teaching. Highlighters are also important. Most of our EMRs require you to print some portion of the discharge summary for patient discharge teaching. And we have what we call an after visit summary, where we print from Epic, and it is not always digestible for patients and families. So we use our highlighters to focus on the things that are most important. And so we always have highlighters available on the unit for this purpose. We are also working with our IT team to just improve the discharge instruction layout to make it easier for the patients to understand. And ask your patients, can you understand these instructions? Or if you have a PFAC, a Patient Family Advisory Council, ask those folks, what their thoughts are on the discharge instructions. Another thing to consider is if English is a second language for that patient, you may also need to print these instructions in their language or offer a translator service to help with discharge teaching. Strategy number 5 is discharge phone calls. So one study showed that more than half of patients that age 70 and over said they didn't recall anyone telling them how to care for themselves at home or after discharge. So the post-discharge phone call helps us identify and resolve these situations. Patients who receive a call have been shown to give better HCAHPS ratings and are less likely to be readmitted. Overall, it just leads to improved adherence and better outcomes. So best practice is that 24 to 48 hours after discharge, the patients should receive a call from a member of the care team. Sometimes it's nurses, in RED, even the physicians call the patients back. But it's important that we measure and learn from the trends from these calls and continue to improve the discharge process. The issue most hospitals have is execution. Who's going to do the calls? And then trying to figure out what are we learning from the calls. So make sure that you have a good way to enter the data from the call, that you track your trends that you're hearing, and that you have a structured approach on how these calls are being done at your organization. And strategy number 6, and my last strategy here is, and I feel like this one is really underappreciated. It's the nurse's role in actively mobilizing patients during their stay. By focusing on mobility, nurses can help improve patients' outcomes. They can expedite their recovery time and really shorten that length of stay of the patients. There are programs designed to improve patient mobility, and those programs lead to greater patient engagement and improve patient experience, as well as bringing back their independence. Many hospitals have adopted tools to improve the culture around mobility and to really assess the patient's functional mobility status throughout their stay. There are tools such as the Hopkins AMPAC, the activity measure for post-acute care scale, and the Johns Hopkins highest level of mobility scale. Those are some really popular ones. And when people are hospitalized and are bedridden, what I learned through doing research on this is that they can lose muscle mass at an alarming rate. In one study, healthy older adults lost 1 kilogram of muscle mass from the lower extremities alone within 10 days of bed rest. And this loss was associated with large reductions in strength, aerobic capacity, and the amount of physical activity. The muscle loss appears to be largely due to decreased muscle protein synthesis. And this high degree of muscle wasting was in a healthy person. So in the sick and elderly, muscle loss could be much worse. So, and even more so, they're also confined to the bed, longer, than 10 days, some of the elderly. So this degree of muscle loss is serious, is really serious business in the elderly, especially if they're already ill. So it's going to take them a long time to rebuild that muscle. And in the meantime, the loss may seriously compromise their recovery and send them into a permanent nursing home or residency. So in conclusion, effective discharge planning and care coordination can help reduce medical errors during transitions of care, which is known to be a time frame which patients are particularly vulnerable. So really planning for discharge should involve the patient and the caregiver and begin as soon as possible during the hospitalization. The ideal discharge planning strategy is to emphasize the patient and the family engagement in the discharge planning and discharge education. And AHRQ actually has a library of evidence-based resources and tools to improve the discharge process and care transitions. So I'd like to thank you all for your time today. And at this time, I'm going to open the floor for any questions.
Well, thank you so much, Sarita, for that wonderful presentation. I know I've got a lot of notes written down here. There's a couple of questions in the chat box. The first one that I wanted to pose to you is, do you include patients in your care coordination round? And what barriers do you find to that?
Yeah, we actually don't include patients in the care coordination rounds, but that's why we have the walking and talking points. That's why that's so important, because there are key things that we discuss that have to be taken back to the bedside, and that's the nurse's role, is to take those talking points back to the patient. We do have patient rounds during the day where the physicians round on the patients and the nurses go in and help. We're really trying to, foster the trio rounding concept a little bit more here, but it's definitely an opportunity for us.
Thank you. The other question is really a question that is addressed to the VHA, no, it is addressed to you. So what are you doing to focus on readmissions for patients who are hospitalized with COVID?
We treat them as we treat everyone else. And we just really try to be proactive and give them all of the tools that they need to leave the hospital with, a good understanding of how to care for themselves so they don't get readmitted. And that's really the focus, is just trying to be proactive. And I think there's enough knowledge out there about COVID now that people kind of get it and they know, okay, these are the do's and don'ts. But we definitely, try to give them all the tools that they need. I do need to kind of pull some data to see what our readmissions look like for COVID now at our hospital. I know that we did have an uptick in the beginning of the pandemic, especially for patients that had to go home with oxygen and things like that, but not so much now. They're not staying as long as they were before either. So that's good.
Yeah. So there's another question that just popped up in the Q&A box that actually crossed my mind, because I know this is a struggle with a number of our hospitals, and that is, how do you assess that these strategies are being carried out, and then their effectiveness as well? With the effectiveness, you did talk about some of your outcomes, but that accountability for implementing these things,
Yes.
how do you manage that?
It's so hard. I have 12 departments, and it's hard. Like, you have to create these processes so that it's easy for you to manage and to validate. You have to be able to validate it, and you have to hold people accountable for the validation. For example, our bedside shift report and hourly rounding validation is done by our patient experience department. And even this morning, I just got an email. We have a schedule, and they round and they validate people to see if they're hitting all the points that they're supposed to hit for these activities, and they email it back to the whole team, so everybody knows there's eyes on it. And then data, that's why I said about the discharge phone calls. You really have to have a database that you're putting this information into, where you can pull the data and validate that it's happening, and then learn from the trends. So that's really important as well. You just have to be transparent and visible, use data, and make it easy on yourself, especially if you're a nurse leader. You have to make it easy for you to get the information that you're looking to validate, because you can't go and validate them all yourself. You can spot check.
I love that you made the validation part of the workflow as well.
Yeah,
so,
yeah. I mean, I always believe in spot checking too. Whenever I have a moment and I get here early enough, I'll walk around and just see if people are doing bedside handoff, and I'll pop in and just say, "Oh, I'm just walking around, just listening," and it kind of lets them know that this is not going away, and it's something that you just have to keep focus on.
Yeah, that sounds great. So Lisa was clarifying. So you create your own data versus and I think this is related to your discharge phone calls. So you're creating your own data there instead of having the call system generated or something like that.
Yeah, and I've worked at organizations where I've done it both ways, and really best practice is to have a live person, talk to the patient. I've done it in other organizations where the patient gets like a robocall, and if you were satisfied with your care, press 1. If you were not, press 2. And then if they press 2, then all those go to the unit to then handle calling them back. That didn't really seem to work out well, but we do seem to have pretty good success with just straight discharge calling everyone that was discharged the previous day. It's a lot. But that's when I utilize, your light duty nurse or somebody like that who may need some extra work. Instead of calling those people off or having them stay home, have them do this and train them up. We looked into a few databases where we could plug in our information, and Epic has some discharge. If you have Epic at your hospital, they have some ways that you can document your discharge phone call and pull data. But we also use a system called Get Well Rounds, or Marbella, where we plug in our rounding data. And that's where we're actually revamping our discharge phone call program to plug our answers and our responses from those calls into that database. It's really good with reporting as well. So.
Yeah, that sounds like a great tool. Well, we're out of time for follow-up questions. I'll let you know. I know because you were presenting, Sarita, you might not have had a chance to watch the chat, but you really have generated some great collaborative networking among some of our hospitals. So thank you for that, and thank you for those who participated in that. Thank you again for a wonderful presentation. And there are folks who are talking now about what you've started here.
Oh, great. Okay. Well, feel free to, you guys can reach out to me, or, I'm happy to have offline discussions as well about it.
Well, thank you so much. I think that there are folks who might be reaching out to you because they're very interested in what you're doing and how you're accomplishing it.
Great. Thank you so much for having me.
Oh, thank you. Thank you for your presentation, and thank you for the great work that you're doing, taking care of patients in the community at the Virginia Hospital Center.
Thank you.
So that concludes this breakout presentation. There'll be just a brief break to give folks time to move from this breakout until their next breakout, which will start at 2 o'clock. So encourage you to have a look at those and choose the one that is most aligned with your interests and with your work. And have a great afternoon for the last couple of presentations.